Hello everyone, can you see the screen now? Hello,
Yes, sir. Yes, sir.
and can you hear my voice also?
Yes, sir. Very clear.
Okay, thank you. So good evening everyone, and today session we have the objectives to sensitize how to assess clinical skills using online platform, to address queries for hands-on exercise for online assessment, what we discussed yesterday, if at all, and to get feedback from participants about their experience of online teaching and assessment. Before we start, can we have the poll?
Yes, sir. Yes,
Can we have a poll?
sure, sir. All the attendees here, you will see on your screen the poll. The poll will stay here for 45 seconds. Please answer as quickly as possible. Can you see the poll, sir?
Yeah, I can see.
I'll be ending the poll in under 10 seconds. Thank you for polling. So I'm going to share the result. Should I?
Yeah, please go ahead. Okay, so 20% have already done assessment, while 80% are still in the process or they have not done it. Okay, thank you, ma'am. So I think we should be able to help many and ourselves also. So let's begin. When we say assessment, we have to keep two things in our mind, whether we are talking about formative assessment or summative assessment or both. So uh, to begin with, I will be focusing on formative assessment, and at the end we can talk a little about summative assessment. It has been tried in some places using e-OSCEs, using Zoom. So we'll talk a little about it maybe at the end of the time, but let's start with focus of formative assessment, because our students have not attended clinics and they have not learned the skills. So our aim is to teach them and assess them and improvise their knowledge and learning. So our aim is right now to focus on formative assessment. So clinical skills we can divide into different categories. From the cognitive domain, we can have eliciting the history, clinical reasoning skills, and decision making for treatment, investigation, planning, etc. For clinical reasoning, it would be like making a differential diagnosis. What are the points in favor? What are the points against a particular diagnosis? And then in affective domain, there would be communication skills. In the psychomotor domain, there would be clinical examination as well as procedural skills. So let's look at them one by one. How we can assess eliciting history? Obviously, if we have to assess it, it has to be face-to-face or online. So we can have online synchronous tools where we can have face-to-face interaction live, Zoom, Zshoot, and even WhatsApp video call. So if we don't have anything, WhatsApp video call can be a good option for us. And there is a option of having group also meeting. So 3-4 people can join together. And in Zoom free version also 100 students can join together. So we can plan in such a way that one student elicits the history while the rest of them become silent observers. History can be elicited from a real patient who has been sensitized in advance that we are going to have your history elicited by one of the students, and you have to give the answers accordingly. If we do not have real patient or the patients are not comfortable, then it's time we have to start thinking of simulated patients. And what are they? We'll have a little idea about it at the end of the presentation. But right now, I'll just say that simulated patient is a healthy person, or it may be a patient who has been standardized. That's another term. A healthy person who has been trained to behave or act like a patient and provide the history. Since we do not have time, it's our responsibility to behave ourselves as a simulated patient. So I, as a teacher, become a patient who has come with pain abdomen, or who has come with chest pain, or who has come with cough and breathlessness. And I ask my student to take a history from me, and I will try to mimic the history of a patient, maybe of cardiac disease or renal colic or pneumonia, etc. So for that, we need to develop scripts, or we can have the help of histories or the records which we already have in our case sheets, or there may be records available from the cases presented by our PGs or UGs in earlier days. In the last few years, whatever histories have been presented, they can be good source to begin with. So faculty can be a simulated patient, residents can be there, simulated patients, nursing staff can be trained, and other office staff like our clerks and ward boys can also behave. And in coming years, I'm sure professionals will be available to behave or act like simulated patients or standardized patients. In US and Western countries, majority of teaching is done by professional, standardized, and simulated patients. So it's time they have to start thinking and start practicing these skills. So I'll just share. Please take a focus history with a patient who has come with chief complaint of chest pain, and there may be possibility that it is a cardiac pain. So this is the cue given to the student, sharing an experience which we had. So since it was a long thing, I have cut it short. Namaste ma'am, if you are able to hear my voice on
नमस्ते,
video.
आपका नाम क्या है?
Voice
मेरा
is
नाम
breaking,
आनंद
sir.
है,
आपकी उम्र क्या है?
मेरी उम्र 60 साल है।
और आप काम क्या करते हैं?
मैं नौकरी करता हूँ ऑफिस में।
किस तरह का काम करते हैं? मतलब फैक्ट्री में करते हैं कि कहाँ पे करते हैं?
ऑफिस के काम में क्लरिकल ज्यादा है।
अच्छा, और कहाँ पे रहते हैं आप?
भोपाल में रहते हैं।
आपको क्या तकलीफ है?
मेरे को मैम सीने में दर्द होता है।
अच्छा, कब से हो रहा है?
ये करीब 2 महीने हो गए।
2 महीने से हो रहा है। तो 2 महीने से रोज हो रहा है, रुक रुक के हो रहा है, कभी कभी किस तरह से हो रहा है?
रोज तो नहीं होता है, कभी कभी होता है।
तो आपने कुछ इसका इलाज करवाया, कुछ दवा वगैरह ले रहे हैं?
नहीं, अभी तक दवाई नहीं ली। लगता है गैस
अच्छा।
एसिडिटी है, तो 1-2 बार घर पे एसिडिटी की दवाई पी थी, पर आराम नहीं आया।
अच्छा, इलाज नहीं करवाया मतलब आपने?
डॉक्टर के पास नहीं गए।
अच्छा, तो ये जो हो रहा है, ये आपको एकदम से आ जाता है कि धीरे धीरे करके दर्द बढ़ता है कि बहुत तेजी से बढ़ जाता है, किस तरीके से?
ये दर्द तो रोज नहीं होता है, कभी कभी होता है।
जी, एकदम से उठता है?
बैठे बैठे नहीं होता है मैम, ज्यादा चलने
कुछ काम करते हैं?
सीढ़ी चढ़ने पे होता है। 2 मंजिल 3 मंजिल जैसे चढ़े, ऑफिस हमारा 4थी मंजिल पे है, तो 2 मंजिल चढ़ने के बाद ऐसा लगता है कि सीने में दर्द हो रहा है।
और फिर बैठते हैं, आराम करते हैं तो ठीक हो जाता है?
हाँ, थोड़ी देर वहां पे रुक जाते हैं और 1-1.5 मिनट में ऐसा लगता है कि अब ठीक है।
कुछ गोली वगैरह लेते हैं इसके लिए? कभी एसिडिटी की गोली लेते हैं और कुछ नहीं लेते?
दवाई 2-3 बार खाई पर फायदा नहीं हुआ।
और किस तरह का दर्द होता है आप बताएंगे? मतलब जैसे चुभ रहा हो, कुछ ऐसा दर्द हो रहा हो, या फिर तड़क हो रही हो, या फिर किस तरीके का दर्द होता है, आप थोड़ा बता सकते हैं?
ऐसा लगता है कि कुछ सीने में जकड़न सी हो रही है, भारीपन जैसा कुछ
अच्छा
दबा रहा है।
अच्छा।
Okay, before this, I would just like to brief a little. You would have seen three people in the video. One was myself, one was my wife. She's a pediatrician and she was having a checklist in her hand, which was prepared in advance. And she was scoring the points, whatever questions were being asked by the student and whatever answers were being given by the patient, the simulated patient. And I acted like a simulated patient as Mr. Ramlal. And the student was informed in advance that she has to take a history considering chest pain. And she was given some time to prepare. And she had probably done some homework to read about it, and then she had taken the history. And moving further, I would just like to know whether you were able to hear the voice clearly, what happened between the two?
Yes, sir.
Okay, fine. Thank you. So a little more about the history. Continue.
दर्द के अलावा आपको सांस लेने में तकलीफ ऐसा कुछ होता है? बुखार आता हो या सांस लेने में तकलीफ हो रही हो?
ये बुखार तो नहीं है, सांस में जब दर्द होता है तो उस समय ऐसा लगता है कि थोड़ा सा सांस लेने में भारी पर तकलीफ हो रही है, पर वैसे
तकलीफ होती है?
जब दर्द होता है तभी
अच्छा,
होता है,
अच्छा।
वैसे नहीं होता।
अच्छा, सांस लेने में तकलीफ होती है मतलब आपको? जी। और आप किस तरह की चीजें खाते हैं? मतलब आप तेल की चीजें बहुत ज्यादा खाते हैं क्या? मतलब कैसा खाना खाते हैं आप?
Okay. Then she continued to ask questions whether you are diabetic, hypertensive, taking any medicine, and completed the history. I'm not sharing the whole of the thing. And then after that, I provided a feedback to the student along with the marks. And this was the checklist which we have prepared in advance. And I would like to validate it again with the faculty in my department. And the marks accordingly were given 29 out of 50 based on the scoring of the checklist. And this checklist was not shared with our student at this point of time.
आपने नाम पूछा, एज पूछी, टेस्ट में पेन का ड्यूरेशन पूछा, साइट पूछा, साइट नहीं पूछा आपने एग्जैक्टली कि कहाँ पे दर्द होता है।
यस सर, मिस हो गया।
सेंटर में होता है, लेफ्ट में होता है, राइट
में
जाए तो दैट राइट पार्ट इज मिस। रेडिएशन नहीं पूछा आपने, कहाँ से रेडिएशन नेक में जाता है, आर्म में जाता है। सीवियरिटी एग्जैक्टली आपने नहीं पूछी थी, हल्का, मीडियम, जोर से, या ऑन अ स्केल ऑफ 0 to 10 कितना सीवियर पेन होता है, बट आपने ये पूछा।
सर अपन ऐसा पूछ सकते हैं पेशेंट से कि आपको हम 0 से 10 की स्केल दे रहे हैं तो आपको कितने पे हो रहा होगा, उनसे पूछ सकते हैं ऐसा।
पर 0 से 10 का मतलब क्या है वो हमें बताना पड़ेगा। 0 मतलब बिल्कुल दर्द नहीं है, 10 मतलब जान निकल जाएगी, 1-2 माइल्ड बियरेबल है, 3-4 तकलीफ वाला है पर चलेगा, 5-6 मतलब दवाई खानी ही पड़ेगी, 7-8 मतलब काम करने में रुकावट है, और 9-10 मतलब मैं बिल्कुल जाने की प्रेसिपिटेटेड बाय आपने पूछा था, किस चीज से बढ़ जाता है?
यस सर।
रुकने से आराम आ जाता है, ये आपने पूछा था। रिलेशन विथ मील एक पूछना होता है, कई बार पोस्ट मील एंजाइना भी होता है, तो वो एक अगली बार ध्यान रखिएगा।
एसोसिएट कौन सा एंजाइना?
पोस्ट मील एंजाइना, खाना खाने के बाद पेन होता है।
सर तो वो एंजाइना होता है या फिर एसिडिटी?
करेंगे, डिटेल में डिस्कस करेंगे। एक बार फीडबैक ले लो, उसके बाद जो आपके डाउट्स है वो आप नोट कर लेना, फिर अपन उस पर डिस्कस करेंगे, है ना। ब्रेथलेसनेस के बारे में आपने पूछा था, स्वेटिंग के बारे में नहीं पूछा, और स्वेलिंग ओवर फीट के बारे में नहीं पूछा। अगर स्वेटिंग हो रही है तो इट इज सीवियर अनस्टेबल एंजाइना या इम्पेंडिंग एमआई हो सकता है, और दूसरा स्वेलिंग ओवर फीट आ रहा है मतलब पेशेंट इज गोइंग इन कार्डियक फेलियर। ये चीजें पूछना चाहिए। स्मोकिंग के बारे में आपने पूछा, अल्कोहल के बारे में पूछा, थोड़ा वेट के बारे में आपको पूछना चाहिए क्योंकि कितना वजन है अप्रोक्सीमेटली, ओवरवेट या अंडरवेट है। आपने लाइफस्टाइल पूछा था, सीडेंटरी लाइफस्टाइल है, किस तरह का काम करता हूँ। डाइट का आपने पूछा, डायबिटीज बीपी के बारे में पूछा, इट इज गुड क्योंकि दे आर एट अ हाई रिस्क ऑफ डेवलपिंग। ड्रग्स के बारे में भी आपने पूछा, फैमिली हिस्ट्री के बारे में भी पूछा, ठीक है ना। तो तो टाइप ऑफ पेन भी आपने पूछने की कोशिश करी थी,
यस सर।
पास हिस्ट्री भी पूछी आपने, है ना, और इन्वेस्टिगेशन भी आपने एडवाइस किए। बेसिकली एमबीबीएस लेवल पे okay. So the feedback was given, and based on the scoring system, marks were given. And this was a student who is in final year at present, and who has attended clinics in second year and third year part 1, but not attended many clinics in third year part 2. So if we can sensitize our student that we are going to have this kind of activity, and we give a scenario or a condition in advance that you have to take a history who is probably having anemia, or who is come with chest pain, or who is likely to have CAD, or who is likely to have pneumonia. So the students can go and uh, open their books and read about the particular topic and relevant differential diagnosis, and over a period of time we can elicit more and more questions related to the history, and after the history we can give the findings of examination, and based on the history examination findings we can ask them to give a probable diagnosis. This interview continued, and I had also requested her to give suggestions for uh, the timing, what investigation I should undergo, what treatment should be taken, and what changes I need to do. So she has given me suggestions for lifestyle modifications, quitting smoking, and many things. So this was just to share our experience, and we are going to have this as a regular activity, and we are developing a little more on this as a project. Moving to clinical reasoning and decision making, it can be done by written test or maybe Viva one-to-one. Case-based scenarios, laboratory reports, charts, ECG, radiological reports, X-ray, and CT scan, MRI, and other things can be used to make a differential diagnosis, analyze the reports, and then what action would be required at that point of time, what differential diagnosis and what treatment and what more investigation will be required based on these reports. This can be done synchronous, online, using Google Forms, as we discussed yesterday, or we can do one-to-one. Case description is shared with the students, followed by questions, and questions should be designed so that they address the knowledge related to analysis, application, and evaluation rather than simple recall or comprehension. So here is a case scenario. If we can give the history and examination findings to the student, after reading this, then we can ask the questions, and certain questions to promote higher order thinking are: what are the possible differential diagnoses? Give the points in favor or points against whatever diagnosis you are making. And out of all the diagnoses, which is the most likely and why? What more information would you like to elicit about the history, or what more information you would like to know regarding examination? What investigation would like to do, and what is the prognosis of the patient, and what treatment you would like to do? So these questions can stimulate the thinking process of the students and promote learning at a higher level. The exercise was done by us using WhatsApp, teaching undergraduates beyond the classroom, and here we had 5 case scenarios discussed online WhatsApp. This was done about 4 or 5 years back, 2015 and 16, as a part of my advanced course. Case scenarios were given, followed by X-rays and ECGs at an intermittent interval, and the questions were asked what I had shared earlier, and appropriate questions were added as and when required. The students responded intermittently, and one important observation what I noticed was uh, the study was done with only few students because it was closer to the pre-university exams, so students were not very comfortable. But thing was, though there was involvement of 30-40% students who were actively discussing, all of the students were reading through it. So even those who were passive were reading and learning out of the thing. So that was a plus point in this observation. So
So moving forward, how we can assess communication skills or counseling? This can be done. Sorry, screen, I'll just share again. Please bear with me. I'll just open the file. The file is somehow closed. Just give me a minute. Kavita ma'am, meanwhile, you can interact and there can be questions. You can note down.
Sure, sir. Sure,
Thank you.
sir. So some people are requesting you to show the case scenario again. And I would request all to definitely fill the feedback mail, because filling the feedback mail will certify you for getting your certificates of 5 days. So please definitely fill the feedback mail, and the feedback has questions on which other topics you would like to hear, timings, weekdays, and also please definitely do let us know if this timing was not appropriate, which would suit you best in the feedback mail, so that we can arrange the next webinar based on the requirements of all the attendees. And we will be dissolving the Google Classroom. So whatever contents you want, please download it. And maybe tomorrow we will dissolve it, so that you will have some time, enough time to definitely go through it. So Anil Kapoor sir is back, I guess.
Can you see the screen now? Hello?
Yes, sir. Yes, sir.
The screen is visible now?
Yes, sir. Feedback to students with marks. Yes, sir.
Okay. So what slide they are requesting to be shown again? You had said some faculty requested to show something again.
Yes, sir. Case scenario, sir. Maybe at the end you can show it.
I can show right through
Okay,
which
sir.
scenario they were wanting.
Kindly show the case scenario again.
Okay. Is it visible now?
Yes, sir.
Okay. You can take any case. This is case taken from a book. 100 cases in general medicine. You can Google out. You will find it on net also. There are different cases. This was just to show an example that that's how we can do. And these are the questions which we need to talk about. think we were here. So, am I audible now?
Yes, sir.
Okay. So let's move forward. Sorry for the technical problem. Communication can be assessed in a written way or in a verbal way. Communication can be to the patients, it can be to the peers and to the teachers. But right now we may focus to the patients and maybe to the teachers if required. When they are interacting with the teacher, things are already seen by the teacher at that point of time. So we focus on patient. One of the way is we can show the videos of doctor-patient interaction or doctor-doctor communication, and after that we can ask them to discuss what went well, what problem was identified, how it should have been dealt, or what you would have done if you were there in the scenario as a patient or as a doctor. Another option is we can have a simulated patient and then we ask the student to counsel the patient. He has been recently found to have diabetes mellitus, or maybe breaking a bad news like he is probably having malignancy, or probably he has got risk of having HIV, so there's a need to get his blood tested for HIV. So certain scenarios may be made and the student has to then counsel the person, the patient, a real patient or a simulated patient accordingly. In addition, we can use the ATCOM module and it has given a lot of suggestion. Case scenarios are already there, so we can use scenarios from that also. And how to assess them, there is a checklist given at the end of the module. We can utilize those checklists also. Example, watch this short movie and comment on. So, this is a short movie which is available on the net. 2.5. We can ask the students, and then it can be discussed in the form of debate also, or discussion among a small group also. It was done by our doctors only, Department of Gynae at Luni. And a lot of things are there in addition to communication.
प्लीज गीता पे हाथ रख के कसम खाइए कि आप जो भी करेंगे सच करेंगे और सबके सिवाय कुछ नहीं करेंगे। मैं गीता पे हाथ रख के कहता हूँ कि मैं जो कहूँगा सच कहूँगा और सच के सिवा और कुछ नहीं कहूँगा।
डॉक्टर साहब, एडमिट होने से पहले आपकी और पेशेंट की जो बातें हुई थी वो आप कोर्ट को बताइए।
माय लॉर्ड, उस दिन हुआ यूं कि मैं एज यूजुअल अपने क्लिनिक में बैठा था जब मिस्टर और मिसेस वर्मा मेरे क्लिनिक में आए। अरे आइए वर्मा जी, आइए बैठिए।
डॉक्टर वो रिपोर्ट्स आ रही है।
क्या बात है? अरे आपके रिपोर्ट्स के हिसाब से तो आपको कोई भी तकलीफ नहीं है, एचबी की कोई तकलीफ नहीं है, बीपी भी वो नॉर्मल है, डायबिटीज की कोई तकलीफ नहीं है और बच्चे की पोजीशन भी काफी नॉर्मल है और आपकी ईडीडी के हिसाब से आपकी 3 दिन बाद की डेट है, तो 1 दिन पहले एडमिट हो जाइए। और मिसेस वर्मा, अगर आपको कोई तकलीफ हो, पेन्स हो, तो इमीडिएटली एडमिट होइए।
डॉक्टर साहब, मेरे और मेरी दीदी की ये राय है कि हम नॉर्मल डिलीवरी का जो ऑपरेशन कराना चाहते हैं, क्योंकि हम हमारा बच्चा कल ही चाहते हैं। गुरुजी के हिसाब से कल के सूर्योदय का मुहूर्त अति शुभ है।
पर क्यों? सब कुछ तो नॉर्मल है, फिर भी आप क्यों चाहते हैं?
डॉक्टर, मेरी मानसिक स्थिति नहीं है नॉर्मल डिलीवरी करवाने की। मैं इतना दर्द नहीं सह पाऊंगी और हमारे गुरुजी ने भी कहा है कि कल का मुहूर्त सबसे शुभ है।
देखिए मिसेस वर्मा, ऐसा नहीं कि नॉर्मल डिलीवरी में कॉम्प्लिकेशंस नहीं होती, पर सिजेरियन में भी कॉम्प्लिकेशंस हो सकती है, क्योंकि सिजेरियन में एनेस्थीसिया देना पड़ता है, तो उससे जुड़ी कॉम्प्लिकेशंस हो सकती है। जैसे एनेस्थीसिया के कारण आपको शॉक हो सकता है, थ्रोम्बोएम्बोलिज्म हो सकता है, एमनियोटिक फ्लूइड एम्बोलिज्म हो सकता है, अटोनिक पीपीएच भी हो सकता है, और अगर वो अटोनिक पीपीएच कंट्रोल ना हो तो आप डीआईसी में लैंड हो सकती हो, और उसके कारण आपकी मौत भी हो सकती है। और फिर बाद में ऑपरेशन के बाद अगर आपने जख्म का ध्यान न रखा तो आपको सेप्सिस भी हो सकता है। तो इतनी सारी कॉम्प्लिकेशंस के बावजूद क्या आप फिर भी ऑपरेशन कराना चाहती है?
हाँ डॉक्टर, हमें सिजेरियन ही करवाना है।
ठीक है नर्स, इनसे एलएसएस का फॉर्म, कंसेंट फॉर्म भरा लीजिए और इन्हें एडमिट कीजिए।
चलो
ठीक है।
ये लीजिए फॉर्म, इसे पढ़ लीजिए और यहाँ आखिर में साइन कर दीजिए। अरे, आपके तो सारे रिपोर्ट्स नॉर्मल हैं, फिर भी आप ऑपरेशन करवाना चाहती हैं?
वो क्या है ना कि मैंने सुना है नॉर्मल डिलीवरी में शरीर की सारी हड्डियां टूटे, इतना दर्द होता है और मैं इतना दर्द नहीं सह सकती।
सच कहा, पर इतनी सहन शक्ति भगवान ने हर माँ को दी है। आप अपने बच्चे के लिए इतना भी नहीं कर सकती? नॉर्मल डिलीवरी में कोई खतरा नहीं है, और सी सेक्शन में कॉम्प्लिकेशंस आ गए तो साइन किया। पीडियाट्रिशियन का चेकअप है।
ऑपरेशन नहीं कराना चाहिए था, मैं बहुत खुश हूँ।
कुछ बातें ऐसी होती है, हम भी कुछ नहीं कर सकते। हमने आखिरी मौके तक ट्राई किया, पर हम बच्चे की माँ को नहीं बचा सके। आई एम सॉरी।
प्रसूति के नियमों अनुसार हर औरत को अपने शरीर पर पूरा हक होता है और इस हक के कारण वो किसी भी प्रक्रिया के लिए हाँ या ना कर सकती है। कानूनी तौर पर डॉक्टर का फर्ज है कि वो किसी भी प्रक्रिया से संबंधित हर समस्या के बारे में पेशेंट को आगाह करे, साथ ही उसकी लिखित रूप में अनुमति दे। मेरे क्लाइंट डॉक्टर चोपड़ा ने ये सारी फॉर्मेलिटीज पूरी की है। सबूत के तौर पर कोर्ट में ओरिजिनल कंसेंट फॉर्म पेश किया गया है और पीएम रिपोर्ट्स के अनुसार मिसेस वर्मा का देहांत सिजेरियन सेक्शन में आई ब्लीडिंग कॉम्प्लिकेशंस के कारण ही हुआ।
हम लोग समाज में जब कोई समस्या होती है तो विशेषज्ञ के पास जाते हैं। रोग के केस में भी हम लोग डॉक्टर्स के पास जाते हैं और डॉक्टर्स जो जिंदगी भर या इनके लिए लंबे काल तक अध्ययन और अनुभव के द्वारा जो महारत प्राप्त करते हैं उसके आधार पर मरीजों का ट्रीटमेंट करते हैं, मरीजों का इलाज करते हैं। अपनी सेवा शुश्रूषा में वो कोई कसर नहीं छोड़ते। ऐसे केस में जब कभी किसी मरीज के साथ में कुछ दुर्घटना या कुछ गलत आउटकम होता है तो ऐसे में डॉक्टर को दोषी ठहराना कहाँ तक उचित है। कहा जाता है कि जिंदगी और मौत ऊपर वाले के हाथ में है। अगर जिंदगी और मौत ऊपर वाले के हाथ में है तो यहाँ हमें सोचना पड़ेगा कि डॉक्टर को कहाँ तक दोषी ठहराया जाए।
So lot of things can be discussed. We can discuss about the communication between the doctor and the patient. Doctor was using a lot of medical terms, and we don't know whether the patient and the relative are understanding those terms like DIC and similar terms. So that would be one way of looking into communication, whether they are at the same level, or doctor should have used or elaborated what every complication was trying to convey. And then ethical issues and professional issues and the moral issues, a lot of things can be discussed on this scenario. Okay, so this will be a very good way of looking at formative assessment between affective domain as well as communication skills. Moving to psychomotor domain, and this will comprise of clinical examination as well as procedural skills. Well, at this point of time, I don't have very much to offer for procedural skills, although some simulations can be used by the students and then they can try at home, but it would be too early to comment too much. Like suturing of a wound can be tried on plain paper or maybe on cloth. And similarly, giving injection may be taught either on an apple or a potato. We can just think about these options, how to give injection. So certain things can be taught, how to give an incision, and that incision can be demonstrated on an orange and ask them to demonstrate. So we have to think in an innovative way, what can be done in a given scenario. But certainly we can do something about clinical examination. So students, what we can do, we ask the students to perform a focused examination of their family members, brother, sister, mother, father, or helping mate, whoever is willing to participate, make a video of it and then share with the teacher. Then teacher can review the video and then give feedback, constructive feedback, what went well, what was missed, and what else need to be done. And then student, after hearing or going through the feedback, improvises, practices, and then shares a new video. In the longer run, we can have these videos played with a group of students, and then the peers can also review and provide feedback. So important thing here to remember is we are talking about formative assessment. So we need to talk about feedback, and it has to be constructive feedback. And that's one thing which probably we were not practicing on day-to-day basis. And it's time we have to start practicing it verbally or maybe in a written way. So I have tried to experiment this also with our students, and I have taken a consent, written consent with the students, and asked them to hide the identity of the relatives as far as possible. So I'll just share a small.
Good afternoon everyone. Here I am going to demonstrate a plantar reflex test. To perform this test, we have to scratch the lateral border of the sole like this. As we can see the plantar flexion of great toe and other toes. It indicates a normal functioning pyramidal tract. Instead of plantar flexion, if we get dorsiflexion or fanning of the toes, it is known as Babanski sign, which is present in upper motor neural lesion and also present in infants, which is normal in less than 24 months. Thank you.
Could you hear what she was saying? Hello? Anyone? Kavita ma'am?
Yes sir, it was audible.
Yes, sir.
Okay. So the student demonstrated plantar examination, and if you had observed it carefully, she was using the pointed sharp part of the hammer. And we usually teach in clinical medicine that it's better to avoid using sharp points or because they are likely to cause injury to the sole, especially if the person is having sensory loss. There are sometimes with neuropathy or diabetes or hemiplegia, paraplegia, etc. So we usually use a blunt object, and preferably we use a key. And the direction of the stroke and the movement should be smooth, and it should not touch the big toe, and it should not go down. So feedback was given to the student. And after the feedback, the student did it again.
Good afternoon everyone. Here I am going to demonstrate a plantar reflex test. To perform this test, we have to use a pointed object which should not be too sharp as it can cause trauma in the patient, especially when patient has lost his loss of sensation in the sole. So I scratched over the lateral border of the sole. As we can see, the plantar flexion, which indicates the normal functioning pyramidal tract. Instead of plantar flexion, if we get dorsiflexion or fanning of the toes, it is known as Vivansky sign, which is present in upper motor neural lesion and is also present in infants less than 24 months, which is normal. Thank you.
So based on the feedback, the student has modified the approach, and now she's using the key and she's reciting also that we should not use a sharp object, and the quality of stroke movement is also improved. So, and she was doing it on her brother. So without any patient, we can utilize, and we can say this is a simulated patient scenario, and this is the best way to learn by practicing with whatever resources we have at our hand. So now I would like to talk a little about simulated patients and how they can be used for teaching and learning and assessment. So the term has been modified to standardized patient. That is a bigger term, and it is going to represent people or actors who are trained properly to play the role of patient consistently and according to specific criteria for the purpose of teaching, assessment, and providing feedback on the performance to the medical students. The standardized word is used because the standard patient are trained to act and react in a specific and predictable way as per the goal of the program. And those who are clinicians and all other people would recollect, whenever a student takes the history, the duration is different. When the PG takes the history, the duration increases a little. And when the consultant takes the history changes a lot. That's the reason students always feel that the patient was not cooperative, and it's a common problem, and it's commonly seen, and I'm sure this would be a global situation. It happens because when the history is elicited for the first time, the patient is a little casual one, and over a period of time he keeps on thinking, recalling, and with experience the teachers would definitely elicit the history in a better way as compared to the student. But here a standardized patient is one who has been trained to give the same history again and again. If 10 people will ask the history, ये परेशानी कब से है, he will consistently say 2 महीने, 2 महीने, 2 महीने and 2 महीने. He will never say कि 10 दिन से थी, फिर 1 महीने से थी, फिर 6 महीने से थी और अब 2 साल हो गए, which is seen with the real patient. And this concept has arisen almost in 1960s, 60s, 70s, when Barrow, a neurophysician, realized, and he found out. It's an interesting story. There was an exam, and during the exam, one of the students scored badly. And then when the teacher was talking about the thing, the patient who was there, he made a comment. मैंने इसको जानबूझ के गलत history दी. He was not very happy with the way he was being examined in history. So patient was not cooperating, and he mimicked the complaints. He changed the findings and complaints. When this was observed, then the doctor started thinking, if this is the problem here, this could be problem again. So it's better to have a person who will not change his history. And that's how the thing of simulated patient or standardized patient comes. So it started as a simulated patient, and over a period of time, it has become standardized patient. So these standardized patient can be of two types. One can be the real patients who are now trained to present their illness in a standardized, unvarying way. If you can recall, there are many patients who have got chronic illness and who are called in every exam. And when I was doing my post-graduation and UG, And I observed one of the patient was so cooperative that he was telling students who were coming, auscultate in the mitral area, there is a murmur. So indirectly he was giving a diagnosis. And there was another patient who has fellow statology. And whenever a student will go for taking the history examination, he will just put his hands like this. See, ये मेरे नाखून नीले हैं और ऐसे गोल हो गए हैं. So he will try to show the clubbing and the things. So things were like that. So these are kind of real patients who are now standardized. And then there are simulated patients. These are the normal people, healthy people, who have been trained carefully and accurately to portray specific patient behavior. And one person can be trained to have presentation of a ischemic heart disease, or it can be acute abdominal colic, renal colic. So many things can be trained, and he has to perform accordingly. And they are trained to even elicit certain signs during physical examination, like guarding, rigidity. So if somebody presses on the McBurney's point and the person is behaving like a appendicitis, then he will wince or he will catch his breath. So everything is trained to the people who are behaving like simulated patients. Many things can be taught. I am not going to cover those in detail right now. It would be a separate session. So in short, these are the people who are trained to follow a script to reproduce a particular problem or the symptoms, and are given a set of guidelines to be followed for certain responses. क्या सवाल पूछने पे क्या जवाब देना है, अपनी तरफ से कुछ ऐड नहीं करना है, और कब बोलना है, कब रुकना है, everything is guided to them. And then they are trained to provide specific patient-centered feedback that students require in order to further enhance their learning skills. So patient feedback भी देते हैं, and then they are trained further to score the performance using a checklist. The checklists are given to these patients, and instead of teacher doing the score, these simulated patients do the scoring. And that's how the competency-based medical education is running in US and Europe. So if we want to have CBME in our country, and if we want every student, say 100, 150, 200, 250 students to be assessed for these things, we cannot have only the doctors or the teachers. We need to have a helping hand. We need to train our EGs, we need to train our interns, and we need to train even our staff, even nursing people. Unless, or we should hire people, train people, or we can request some patients who are there chronically with us to come during exams, and then they can also be trained to behave like standardized or simulated patients. So we need to start thinking, are we ready for it or not? Okay, so this was my presentation. If we have any queries for hands-on exercise for online assessment, which we had yesterday, we can go through it. And
sir, do you want to have your poll?
Yeah, that would be a good idea to have the poll before we move other. Please, thank you. So please respond on a scale of 1 to 5, how comfortable you think you are now in organizing online assessment of clinical skills of UG students after attending this webinar. 1 to 5, 1 means not at all and 5 means very much. How many participants we have, ma'am?
Sir, 93.
Okay, fine. So can we have the response?
Yes, sir.
Okay. So there are nobody in level of 1 and 2 and 3, 4, 5. So 25 in it. Almost all have found that probably now they are more comfortable as compared to before. And I'm sure some of the tips what we shared today can be used and applied in different ways, and you can modify and innovate in further. And I would be happy if you can share how you are doing at your place, and that would be really a learning experience for all of us, and it would not be wrong to say that COVID virus, COVID-19, has been a major change agent in medical education. Whatever we are doing right now, or we are talking and thinking about, would not have been possible for next 15 to 20 years if this virus would not have been here. So what is everybody's opinion? You can share in the chat box also, or in the question answer session. Do we have questions, ma'am?
Yes, sir. Sir, you can see it in the QA section, sir.
Okay.
I think difference between simulated and standardized patient has already been answered.
So standardized patient is a bigger thing. Simulated patient is a part of it. Standardized patient can be real patient as well as simulated patient.
So somebody wants, sorry, they want to know, wouldn't it be time consuming to attend to one student at a time? So what could be the solution?
Well, if I compare this with my experience, we have a clinic posting of 3 hours, and most of the time actually it goes for 2 hours. And in 2 hours, 1 hour the students are preparing the case and the teacher is waiting or doing some other work, and in the remaining 1 hour, the student is presenting the history examination. And what is commonly found is the history is discussed, the examination is discussed, and a lot of flaws are found in the history examination. Diagnosis is discussed to some extent, and investigation treatment are hardly discussed in 3 hours time. Here, with my experience of 2-3 students, what I am sharing, it was 15 minutes interaction. The student was informed for the chest pain, taking the history, counseling, and planning investigation and follow-up with the students who have not been attending the classes regularly and clinics regularly. It took me 15 minutes. And then I asked them to reflect on it. How do you feel, and give your feedback. And feedback was encouraging. And if I'm doing it for one student in 15 minutes, and if I have it on a Zoom meeting with free version, we will have 98 students who will observe this interaction, how the history is being elicited and how the feedback is given. And after 15 minutes, we elicit another history by another student with pain abdomen, or maybe chest pain but with pneumonia. So if I give this exercise to students maybe 1 day in advance or 2 days in advance, tomorrow you have to elicit a history of chest pain. One would be having pneumonia, another patient would be having CAD, ischemic heart disease, another patient may have herpes zoster, another patient may have a psychological problem or anxiety neurosis. So they may come prepared with those things, and then they are eliciting the history, keeping those things in mind. I think we have to find some way in between. And after some presentations, we can then start giving. Today we'll have a presentation. We don't tell them what we are going to have complaints on the day. But to begin with, I think it would be a good idea to start with giving the hints, some signs, some symptoms, and another thing is, after giving the history, we can give the signs, that these are the signs. Suppose I'm presenting a patient of anemia, I can show the images with flattening of the nails, platynychia, or hyperpigmented knuckles, which is a B12 deficiency, or CBC report where MCV is very low or it's very high, beyond the range, and then ask the student to interpret what could be the cause. We need to innovate the things, and we can do in the 3 hours what is allotted to us, or we can do at ease in the evening, early morning, late evening, or night hours, where whenever we are comfortable or students are comfortable. So, and then we can record it, and then we can post it on YouTube, and other students who have not seen it, they can go through it and practice and rehearse again. These are certain ideas, and I am not saying that this is the idea. This is one of the ideas. We can always think of more ideas and share and plan accordingly. It would be a good idea if somebody does at their institute and then share with other institutes. They can also get benefit out of this, because it's a national problem, rather global problem. Then asking history from the faculty will be very intimidating. Yes, if you think, yes, but if you think that you are not teacher, I gave the students in advance, I cut down the presentation. To begin with, I told the student, for the next 15 minutes, please forget that I am a doctor, I am your teacher, I am a patient. I will behave like a patient and don't be afraid with me, and I will behave sincerely like a patient. And you behave like a medical student, you are taking a round in the hospital just like I history, you have to do it like this. So we should be mentally prepared. Yes, we have to change first before we want students to change. But I don't think it will be very intimidating. Let us start with simple cases where you don't really need sexual history to be elicited, you don't have questions related to genital problems, and over a period of time, I'm sure we are matured enough and students are matured enough, we can always take the history for skin and BD diseases also. This is what we are teaching in our wards. And when you say I am behaving, you change your name, you change your age, you can change your gender also. So I am Mrs. Ramvati, I am 32 years old and I have got burning micturition. And then somebody asked me that do you have relationships with other people, then I should not hesitate to say yes, I have. I'm not married or I am now divorcee and I have family personal relations with 3 or 4 people. I think we have to change ourselves. And when you are saying that you are behaving like a standardized patient or a simulated patient, you are not the real you. So you have to come out of the real you and you have to behave like the standardized patient. And at the end of the presentation or history eliciting, then you can be a teacher and give feedback as you would like to give. And one of the important thing here I would like to highlight is the process part of eliciting the history is missing in day-to-day clinics. We allow the patient to the students and say, go to bed number 5, go to bed number 10, or go to see Mr. Ramlal and let me know when you are ready. Here, you are observing the whole process yourself. The student is eliciting the history, what mistake student has done, and how they should be corrected. This is the best way of teaching students and identifying their problems. And even in exams, you will find, even when they present the cases, you'll find that many of the students will go through the file. They just go through the file, what are the findings there? Or they will ask the PG, sir, iski diagnosis kya hai? And then they will try to present it accordingly. Now here the student doesn't know anything about what is going to come. So I think this is one of the good ways. Let us try it, let us experiment it, and then share our experiences. Okay, in our institution, we share the checklist during the training program. Yes, this was an experiment which we did right now, but it is good idea to share the checklist with the students that these are the things you have to ask whenever you are eliciting the history, or these are things you have to ask for examination. What examination findings you are looking for? We are looking for hepatomegaly, you are looking for ascites, you are looking for fetal edema, you are looking for raised JVP, they can always ask. And we are preparing the checklist, we will validate it and we will definitely share with our students. Without that, it will not help. But even otherwise, when we train them, when we teach them in the clinics, we always tell, these are the points you have to ask. When you are asking about pain, you have to ask about onset, you have to ask about the site, then radiation, and then what is the severity. Everything is taught, but only thing is we don't give the checklist. It would be a good idea to share the checklist in advance and let them ask on the thing. Because eliciting history is one thing, but interpreting, analyzing, and making a diagnosis is totally another thing. So to begin with, our aim is to improvise their history taking. Once they are good in history taking, we can move to the next level, making a differential diagnosis and plan of investigation and treatment. So we need to share the checklist. The difference between simulated standard patient we have done.
Sir, one of the attendees wants to know about Google form. She wants to know how to number the options alphabetically and how to make the questions bold.
How to make the questions
bold?
There is no option of making the question bold. You can make in capital, all capital or all small. I'm not aware of it if there's an option. Numbering, you want to number the question, that's what the person is asking?
Alphabetically.
What does it mean alphabetically?
maybe there is a reshuffle option. If you want, I think that can be chosen if I have got her right. So that's what.
So you want to know how the reshuffling of the questions can be done for different students?
Unlikely, sir. She wants to know how to number the options alphabetically.
Okay. You want to change the option sequence? You want to move the option from above below? That's what you are looking for?
Yes, sir. If she wants to have the one starting with coming up as first option and B coming up as second option.
There is nothing like A, B, C, D here. There are the things you have to just put a dot on the particular thing. We don't find any A, B, C, D like that. Let me close this and come back with the email part. So give me a minute. So can you see the screen now?
It has started, so not yet. Sir.
Okay, I will just wait for a minute. Please
yes,
let
sir.
me.
Gmail.
So Gmail is now open. And let's go and see the quiz. I'll open the quiz what we had yesterday. Do you want me to open the thing right from the beginning? So just to have a recap. Okay, this is the student version we are seeing. Okay. Let me start from the beginning. We go to my Google Drive. So here is the list of the quizzes what we have made earlier. Important thing here is to remember, if we are planning to shuffle the question, then we should not give number to the questions like 1, 2, 3, 4, 5, because when the question shuffle, the number of the question will remain the same. You'll find question number 5 on the top and question number 2 at below this, and question 1 may be below this. So it would be better not to give number. Don't number the questions if we are trying to shuffle them.
Yes, sir. That would be the better one. She can choose to set it according to her order, preferably in alphabetical. But if it does not work, then shuffle would be the best option.
Options can be shuffled in the within a. We can shuffle the options from one above below easily. That's the. There are 6 dots. Okay, we are going to Google Classroom. Let me come from my inbox only. So here we are. We click on the 9 dots. We go to the Google Drive. This is easy. From the Google Drive, we select one quiz which we have made. Okay. So here we are. Here you will find that we have not numbered the questions. And if we want to change the option, this 3 week, 4 week, 6 week, 8 week, by mistake we have done something wrong. So we have an option of changing it. Either we can do manually. I can change it manually. That's one option. Or there's another option by shuffling the answer. Whatever we select, you will find 6 small dots here, and we put our mouse cursor here. You'll find a plus sign, and now we can simply press our keypad and then move it. It will move up and down. You want to move it down, you can do it. So press the left key of the computer, select it, and then you can always move it up and down wherever you want to do. Can you see the movement? Hello?
Yes, sir.
So this is one way. Similarly, we can change the question order from above downwards. If I want to shift this question above the previous one, here are 6 dots on the top. We select this by pressing on the left and then move it and then leave the thing and it moves up. We need to select it and then move it using the computer mouse, the left, what we say, the left one and the right one, the big keys. So this is how we can change the sequence. Anything, if we want to add one, we can add options and we can make it like this. But whatever we do, unless we click on done, it will not be saved. And we need to make it mandatory, then we will make required. If we make it not mandatory, the student will be able to complete the quiz without answering all the questions. But if we make it mandatory, required, then student will not be able to submit the answers without responding to each and every question. And it's nice because there is no negative marking. And then we have to select the answer key. If we are changing the answer key, and then numbers, how many numbers we want to give, we can increase or decrease the numbers. We need to choose the correct answer. If we want to change the correct answer, we can move the and unselect the other one. And after doing all this exercise, we need to click here on the done button. Unless we do it, the changes will not be saved. And these things automatically are saved in our Google Drive. There was one more thing which I think I forgot to tell, or probably people might have. Yeah, here is an option of going to presentation and shuffle the question order. So if we unselect it, then the questions will be shared as they are given in the order. But if we click here, shuffle the question order, then the number can be rotating. The questions will go in a different way to different students. If we are not making sections, it's not necessary to make sections A, B, C, D. So if we are not making sections, then there's no need to show progress bar. Progress bar is helpful only when we are making sections A, B, C, D. Important thing is to remember, unless we select the quiz, we will not be able to give grades and marks and numbers. So to begin with, we have to click here for the quiz, and then we should start making the questions. Otherwise, we will not be able to give marks. So this is one thing we need to start in the beginning, and then options for the quiz to release the grades immediately after each submission. That means we have all the questions which have got one single answer which are already fed in, and computer will do automatic scoring and the numbers can be released immediately. But if we are having certain questions which the students have to write answers, provide words, and we are not sure whether computer will be able to gauge them correctly or not, then we should select later after manual review. So we need to keep in mind whether we want the student to know the marks immediately or they should know the marks once we review it and then we allow the marks to be shared. And these are the three respondents can see missed question, correct answers and point values. That's an important thing. And the responses, once we click on the responses, there is something more to it. Now you will see a red button here. That means accepting responses. If we change it, now if somebody wants to respond, they will not be able to respond. They will not be able to open the quiz and they will not be able to submit the quiz. So that's how we can control the students and the time for submission. So if you want students to respond, submit, we should do it like this. Another thing, once we have shared a question and we want some modifications to be done, during that time we should always go back to not accepting responses. After this, we should change whatever questions we want to change, minor changes in the options or whatever change we need. After doing the changes, then we should open it for sharing the responses. So many times we'll find that I'm not able to submit the response. It's possible that the person who's created the quiz has blocked it for submitting more responses, editing it further. So this is important thing to be kept in mind. And then there's one more thing. This is a plus icon, create spreadsheet. I want to see the answers, create new spreadsheet, and then we have to go on here, create. So we have to wait for some time and all the participants' answers would be seen here as an Excel sheet. This can be downloaded and saved in our computer for further things. So these are the timings and let me go through whatever we are seeing, the email address, the scores, then every question and their answers, whatever they have given, all the questions, and then we can do the statistical analysis using different tools. That was one thing which I think I did not cover yesterday. And then this was the summary of the responses, what insight we get. So we get beautiful charts ready-made and we can just copy them and put in our presentation or take it for publication. And for every question, we can have analysis how many questions were answered by the participants and how many were right and wrong. So if we find some question which was answered by very few students, that means we need to take that question again for our students and we need to teach them, or maybe their concept is wrong and we need to improve their question concept. So this will help us in improving the students. Like here, the students have responded, very few students have responded correct answer. And we don't expected you to fill the correct answer. Our aim was here to just click on any option and let's see how it works for you. So don't worry for you. And one more thing I would like to share here, when we are sharing the videos, we need to remember that video should not give the diagnosis. So we should see the video in advance and we should be sure that the video is not talking about the disease and the diagnosis. Otherwise, that would be seen by the student and then they can give answer accordingly. So few cautions we need to keep in mind, and then the individual scores by the name. We can see like this, we can go down and then the graph. How many people have responded? So this is a modified thing. So this is how it will look when we try to analyze the responses. I have responded to 1 or 2 people and I will try to respond to rest of the people who have made their Google quizzes in upcoming 1 week time. So please give me some time. Another thing was, these are certain things which we can have get email notifications for new response. So every time somebody responds, we'll get a message on our mail that somebody has responded. And then we can unlink the form when we don't want to use it further. We don't want students to see the link also. or they don't respond to it, we can unlink the form. Also, we can have option of printing all the responses, and we have option of deleting all the responses. Suppose we want to use the same quiz second time with different set of students, we have to first delete all the responses. Then it will be 0. And then this can be used again for the new batch of students, because unless we delete the responses will keep on adding further. Suppose right now I have 62 responses. If I don't delete it and now I post this quiz to another batch of students and they start responding, I will not know how many of them were old people and how many of them were new. So before we share this with other people, we have to delete all the responses. But before that, we need to make this thing, take convert this into a spreadsheet and then select the file. It's still loading, we'll wait for some time. Select it and then make a copy or download in our computer, either in form of PDF or whatever way, Excel sheet, so that once we delete these responses, our data is saved. But it would be better to download all these things after completion of the responses. Don't do it every day, now and then, because this is automatically stored in the Gmail. And this is icon for preview, which I'll just try to show again. This is how it will look to the students. And my suggestion is, when you are doing it, please don't make the sections in the beginning. Keep the section part at the end. Otherwise, you will have to respond to all these things to see further. If I try to see further, this will not allow me to move further because I have to submit here. Okay, then I have to select any question or any option here. Only then I would be able to see what are the questions subsequently. So this should be done at the end. Any more questions, ma'am, or queries?
One question, sir. If Google form gets deleted, can we recover it?
Pardon?
If Google form gets deleted, can we recover it?
If we don't delete, they will not be deleted. If we delete, then it would be difficult, but it would be a good idea to copy and save it in another name. So what we can do, I demonstrated yesterday also. I select one, double click. There's an option of sharing. I can share it with another Gmail ID. If I have 3 Gmail IDs, I can share it with another to myself or my friends or my colleagues on their email IDs, or I can make a copy of it. So I make a copy and save it separately. And if I want to use it after maybe 1 month or 2 months, if I know what date I would like to use it, I can rename it, right click on it and rename it. Since it is a copy, original is still there, and I can save it with the name which I would remember, new. New means I'm going to use it, and if I'm going to use it in the month of July, I will put the date, and I want to use it on 1st July, I will put the date, and then I can say save, okay. So whenever I have to use this file in future, I can use it, and here once I open it, there are no responses here, or if there are responses, we can delete the responses, because this was a quiz which we have made and there was no response to it, so it was like that. If we want to say another file which we have responses also, let's try that, how it looks. So we go to the Google My Drive. and move up. Here I am seeing another page. And if I'm not able to see the particular one, I can scroll down my mouse and see here copy of phase 1 online and the original one. This was made on 24th May. Okay. This was the phase 6 1.1. I think when we save with another name, it's not taking the forms. Let's try again. Make a copy. It's always a good idea to create a new file, copy it and save it. And you don't have to worry, or you can save it in a computer, or if it is safe in the Google Drive, there's nothing to worry. So this is the new file which is now seen. There are no responses seen right now. So it's fine. I'm not able to find the file. Okay. So we need to just remove the responses. Sorry. We can unlink the form so other people will not respond. But important thing is once we delete all the responses, we will not be able to get them back unless we have saved them in Excel sheet or we have saved as a different file. Any more questions, ma'am?
No, sir. Are we through, sir?
I think I'm done from my side.
Okay, sir.
We can have feedback from some participants if they want.
Sir, we will be yes, sir. We will be sending them the feedback link tomorrow in their mail. So you can please feel free to respond about whatever you felt good. And we will definitely consider each and every feedback that you will send us. And now I'll come to the word of thanks. Yes, sir.
Yeah. Just one more thing I would like to add.
Yes, sir.
So far, what we were talking about was about formative assessment of the student. If you are looking at the summative assessment, people are working on e-OSCEs now, where they are having the OSCE stations and the standardized patient or simulated patients available. Now the same thing is being done on e-OSCE, and the student will be going through Zoom in different rooms. A paid version of Zoom has got a facility of making into separate rooms. The student will be entering in one room, then from there he will go to second room, third room, fourth room, and in every room there would be one patient and one observer, or maybe two observers, and the task would be assigned to the student before entering the room, like please elicit the history of pain abdomen. In the second, counsel the patient, and after this, suppose these are the findings, what will you do? And after seeing the patient in the previous room, these are the X-ray report and ECGs. Now try to discuss and analyze. So E option of eliciting e-OSCEs are now under process and being done. We may take some time, but I'm sure we will also be doing, because DNB exams are being held in India, and many of the subjects have OSCE stations. I'm sure ENT pediatrics, there is an OSCE, and there may be many other subjects. We are already running OSCE stations in the DNB exams. So I'm sure they would modify certain things and they will come with e-OSCE. Only difference is they would not be able to elicit the signs on the patient. So that much part can be given to them verbally, that these are the findings on examination. So now how do you progress further? So that's how we can do. And if you want them to demonstrate the science, we can ask them to demonstrate the science on their family members, just like we did planter. We can ask them to demonstrate other things and make a video and share with us. Time limit can be made, and then they have to complete the task in the time. So things will come gradually. We are into it, and let's hope more innovations will come. Wait and watch. Thank you. So over to you, ma'am.
Thank you, sir. Thank you. It was a very nice and elaborate session. Now we come to the end of our 5 days webinar marathon, I should be saying. And it was even new experience for us as a MU team to conduct a webinar, and that too hands-on. I hope we have tried our best, and hope it has been capable of reaching you in whatever level you could imbibe with. And we will definitely try to work on improving it further. So today I have to thank, and when I say thank you, it is not just 2 words. It will be emoting my emotions on behalf of all the team members. First and foremost, the Almighty, obviously, because it went without much hiccups and it was smooth, irrespective of low bandwidth or connectivity and internet and other glitches. I have to thank our dear management, who has always been very supportive, encouraging, and has provided us each and every support from the day 1 to go. I thank our registrar, Dr. Nirja Malik ma'am, and our Dean Academic Affairs, Dr. Mittal sir, Mr. Professor Mittal sir, who has been a strong support during these 5 days and from the moment this thought was incepted. I thank our Dean sir, Dr. Anil Dikshit sir, our ex-Dean, Dr. S.K. Sadavarte sir, our Vice Dean Administration, Dr. Major V.K. Yadav sir, Vice Dean Academics, Dr. Manjunath sir, who is also our member, for their untiring support, encouragement, motivation, that you are doing well. That meant a lot to us. Thank you all. I thank our technical support, Mr. Anjul Rai, who is Assistant Professor in SORT. Without him, I think we couldn't have definitely been done. He has been quite patient with us. When we tried, we goofed up, he was still there supporting us. Thank you, Anjul. And I would like to thank Mr. Deependra Srivastav sir, the PR head, who made us beautiful brochures and who will be helping us with certificates. Thanks a lot, sir. And I would like to thank my full team, Dr. Manjunath sir, Rekha ma'am, Kailash Charokar sir, Dr. Anil Kapoor sir, who have been on toes for all these days and even before, helping, adding, motivating. Without anybody, it wouldn't have been successful at all. Thank you, thank you, thank you a lot to all my team. And last but not the least, of course, the participants, the registrants who have been in 500 plus, the attendees who have been in 200, 300 pluses, and all the people who have been very active throughout these 5 days. I thank you all for making it a successful event. If by any chance I've missed out anybody, do consider my heartfelt thanks. So we will end this webinar. We'll definitely come in future with much better webinars. Thank you.
Thank you, everyone.
Thank you, everyone.
Thank you.
Thank you. Thank you, everyone.